Good morning, Perna.
Good morning, Dr. Bass.
Did you have a nice weekend?
Yes, I did. Just stayed home, did some reading and stuff. How about you?
Well, similar kind of a weekend, mostly home.
Yeah, that's the new way to spend a good day.
Yeah. We'll get going in just a moment.
Yes.
Okay, I guess we should get going. Let me share my screen. All right. Good morning, everybody. All right. So today we're going to do, as usual, a potpourri of EP, somewhat brief for the usual conference. So this is a conference that I actually gave, I guess, 15 years ago. I was looking through my old files and saw some interesting tracings. I thought I'd redo it today since 15 years ago, most of you were probably in high school or junior high school. Okay, so first we'll start with a discussion of calcium channel blockers. Some of you may remember that we reviewed this many months ago, but sometimes repetition is useful. So the main calcium channel blockers that we deal with in pediatric cardiology are verapamil and diltiazem. Both work to slow the calcium channel cells of the SA and AV nodes. They depress automaticity, decrease conduction velocity, and increase refractoriness in the AV and SA nodes. And for this reason, they're very good at treating AV reciprocating tachycardias involving the AV node. And a good example would be ORT. And it's important to remember that until adenosine was commercially available, which was really not until the late 1980s or early 1990s, verapamil was the #1 treatment for SVT acute management if you really needed it to stop relatively quickly. Otherwise, people would give things like digoxin and wait hours until it would terminate. Interestingly, verapamil does not have any direct electrophysiologic effect on atrial or ventricular myocardium, except slow channels may be important to myocardial early after depolarization, which may play a role in some types of arrhythmias, with the classic example being so-called Bell-Hassan's tachycardia, which is a name for LV outflow tract tachycardia. And this may explain the efficacy for these medicines for that type of tachycardia. And I've certainly seen more than one patient who responded with Bell-Hassan's to calcium channel blockade. And it's quite sudden and remarkable. Both agents are well absorbed from the gut, but only 30 to 40% is bioavailable after first pass metabolism, and very little is left when it's excreted in the urine. The elimination half-life is 5 to 12 hours for verapamil, and it's shorter for diltiazem, 3.5. And both can be given IV, but it's very important to remember that verapamil is quite hemodynamically embarrassing. If you give that agent rapidly, it will universally cause hypotension. And one of the difficulties or challenges when using IV verapamil, and one of the reasons that I don't generally like to use it, is because it comes in a very concentrated solution and it's very difficult to give it slowly. So even though you try to give it, let's say, over 5 or 10 minutes a dose, almost invariably, it seems like everybody, almost 100% of patients become hypotensive from this medicine. So generally speaking, I prefer not to use IV verapamil except in real emergencies. And as I said, the side effect most important is hypotension, particularly with fast pushes, particularly with verapamil. It can depress myocardial function. These agents can cause constipation, which I think is the most common side effect for people who are chronically on it, and it's not very common. I think it's something like 5% of patients. Dizziness, nausea, and headache. And it can cause AV block transiently, but this is usually only seen in patients who already have pre-existent AV block. So if you don't have that, probably you'll be all right from that perspective. And some drug interactions that are important. Verapamil will increase cyclophosphamide levels, theophylline levels, and carbamazepine levels. And diltiazem also increases cyclophosphamide and carbamazepine levels, as well as digoxin levels. These are certainly interactions that could potentially be asked on your board examination one day. Okay, let's move forward. Of course, it's very important to remember that both agents, all calcium channel blocking agents, are contraindicated in WPW because of the theoretical possibility that they may enhance accessory pathway conduction and therefore enhance the possibility of life-threatening arrhythmias, particularly atrial fibrillation that is rapidly conducted. It is theoretically possible that giving these agents can cause enhancement of the pathway, and what was rapidly conducted AFib will become VFib rapidly. And for the same reason, digoxin is also contraindicated. And I recall well a patient who received digoxin in that setting because the cardiologist did not understand what they were looking at. And unfortunately, that child died of a very difficult to control VF. So very important interaction, very, very important. Okay, so let's move on to our first tracing of the day. And I think I'm going to ask Dr. Uzoma Obiaka what she thinks this is and how she would acutely and chronically manage this. Good morning, Uzo.
Morning, Dr. Pass. So looking at the tracing, looks to me to be a wide complex tachycardia that is seems to be irregular. Yeah, so it seems to be very complex tachycardia that's irregular. So I would say, usually you tell us when we have those two things, then we should think of the rapidly conducting AFib.
Right, and it's also important to note that it's irregularly irregular.
Yeah.
Right? Okay.
Yeah.
So when you have a wide complex tachycardia that is irregularly irregular, you should correctly, as you said, think about rapidly conducted atrial fibrillation. Now, you guys probably have noticed that this type of ECG shows up in virtually every third EP conference. I'm doing that because I don't want anyone in this room, virtual room, to ever miss this diagnosis. This is one of the few times that you will be on your own and you will have to properly manage this. And I don't want to ever hear that what happened to that cardiologist that I mentioned earlier would ever happen to you, and I know it won't. So Uzo, you are in Baton Rouge, Louisiana, doing a locum tenens. You're in the emergency room as the cardiologist, and they're asking you how to manage this. First of all, Uzo, do you think the patient is conscious or unconscious while they're sitting there in this arrhythmia?
I think the patient is conscious.
Right, the patient could be conscious, and that's important because sometimes we think that when we see a rhythm like this, that a patient would have fainted already. Now they may faint, but and it's not uncommon that somebody with this type of arrhythmia will come in with a history of having fainted and still being in this. And how fast is this rhythm roughly?
So this looks to be about 300.
Right, it's pretty fast, very, very fast. So, okay, so you're now in the emergency department out in Baton Rouge, and they want to know this fresh, newly minted cardiologist. What do you want to do for this?
So, I mean, we already talked about the patient being awake. So patient is awake, conscious. So I would assume by that question, you were also trying to ask me hemodynamic stability. So I would assume the patient is also hemodynamically stable.
Well, they are stable, but I should say they're conscious. That doesn't necessarily mean they're stable, right? I mean,
Yeah.
I really only asked the question because I know that when I was at your stage of training, I sort of assumed that if you had this EKG, you basically were unconscious. And I'm really just emphasizing the fact that patients with this type of rhythm, they may not stay conscious for very much longer, but you do not necessarily, this does not always equal being unconscious. But in this particular case, let's assume the patient is conscious.
So procainamide would be my go-to for this patient.
Right, so you could give procainamide. Would you like to hazard a guess as to dose of procainamide?
So 20 to 30 mics per kilo loading dose.
No,
That's what I'm thinking.
it's 5 to 10.
5 to 10 load. Okay, and
Right.
then yeah.
And, you want to start about 20 mics. It's actually 5 to 10 I believe it's milligrams per kilo, and then it's 20 mics per kilo per minute as an infusion.
Okay.
Okay, so you could do that, but they say to you that there is a nationwide shortage of procainamide. They said that sounded like a great idea, Dr. Obiaka, but in Baton Rouge, we haven't gotten our supply of procainamide. So what is there any other option we can do?
We could also do lidocaine.
Lidocaine. What is your theory about that?
I was just thinking it's well, I mean, it's an atrial. I want to say it's a ventricular rhythm, but it's really an atrial. So
that's correct. Lidocaine really would not be the right option. Yeah. I mean, interestingly enough, about Dr. Ed Walsh in Boston used to say that something like 10% of SVTs will terminate with lidocaine, but that would not be that would be my only if it was my only option at all. I might do it if I had no other choices, but it probably would not be my first, second, or ninth choice. So
amio, I would do amio.
You could give amio. Yeah, amio might slow everything down in an unpredictable manner, but probably safe. And how much would you give of amio? Let's say this is a 10-year-old.
So I would do. I know we can load anywhere from 10 to 20 per kilo.
No, that's true that the total daily dose could be 10 to 20.
Sorry, that's a total daily dose. So maybe I would load. Okay, actually I would load for the atrial rhythms, we do like a 5 per kilo. So I would do a 5 per kilo load.
Okay, so let me take a step back. Anytime you use IV amio, the formal official loading dose for children is 5 milligrams per kilo. And typically it's given over, the official recommendations is like over 20 minutes, but I normally recommend giving it over an hour because it can be very hemodynamically embarrassing. Some doctors give a little less, but then what you're referring to in terms of 5 per kilo or 10 per kilo or 20 per kilo is whether you're treating an atrial or an SVT or a VT. And you're correct that for ventricular arrhythmias, we typically give a higher dose. For atrial or SVTs, we typically give a somewhat lower dose. But right now, to sort of acutely treat it, you could give amio. Okay, that's good. Now let's, what about verapamil? We just talked about verapamil. Is that a good agent in this setting? Uzo?
Sorry, I was muted, sorry. We just no, it would not be a good choice just because of the rapid conduction. So it could potentiate AFIB. So we wouldn't give digoxin or verapamil for those reasons.
Correct. Okay, good. Just checking your short-term memory from 5 seconds ago. And so let's say that you don't have amiodarone. So you've gotten this question right for sure. Proc would be a good choice. Amio would be a good choice. But you don't have either of those. What's your next option? They don't have those newfangled medicines in this emergency room.
Can I cardiovert this patient?
Yes, you can cardiovert this patient, but how are you going to do that? Patient's awake. They say, I don't want to get electrocuted.
So I would give the patient a small amount of, I would sedate the patient.
Yeah, well, the answer is you would call an anesthesiologist.
Or the ICU attending, yes, I would call somebody to sedate this patient.
Sedate the patient. And actually, emergency room doctors can sedate patients for procedures also. Although in some ERs, they prefer to call anesthesiology to do that. Yeah, you would sedate them. And then how much energy would you give the patient?
I could do 0.5 to 1 joules per kilo.
That's right, because this is really a supraventricular arrhythmia, so it should respond to that. Some people would say that for atrial fibrillation, like in the adult world, there's actually quite a big literature showing that if you give 200 joules to everybody, that on average it works better than doing the 0.5 to 1 per kilo. And you could give 200, although that would probably be inadvisable. You remember that shocking is a myocardial depressant, so you have to be careful with that. But yes, you would give 0.5 to 1 per kilo. And anything else you would do in terms of setting up the defibrillator to make sure this is a safe defibrillation?
In terms of syncing?
Yes, in terms of syncing, exactly.
So you could sync.
I could sync or I could not sync.
But you don't, yeah, this is okay, because I'm looking for.
So should we sync or should we not sync? So let me ask you a first question. When you sync.
You sync to the QRS.
You sync to the QRS, correct. Why do we sync to the QRS? Why do we care about syncing to the QRS? What are we trying to do by doing that?
If we sync inappropriately, say if we cardiovert when we're like say on a T wave or something, and we could keep the patient, like we could have like an RNT and keep the patient into like a ventricular arrhythmia.
That's right, usually VF. In fact, that is, that when we put defibrillators in patients, one of the protocols that is inside of all defibrillators is putting an R on T. To try and induce. That's one of the more standard mechanisms to induce VF when we put a defibrillator in and acutely test it. So it's a very effective mechanism for causing VF. So yes, so you want to sync to the QRS because you want to, when you sync to the QRS, the device makes certain that it will not deliver a shock on a T wave.
And we will sync this one.
Say that again?
We would sync this.
Definitely you would sync this. And I also would remind you, and I've made this point before, but it bears repeating. When you sync, it's very important once you press the button not to touch the patient until the defibrillation has been delivered. Sometimes, if the device is having difficulty syncing, it may not deliver that. You'll press the button and nothing happens for a second or two. And rarely people will say, what's going on? Why is it not defibrillating? And it's because the device is having trouble syncing. But once it thinks it sees a QRS, it will deliver the energy. And so you never want to touch a patient. Once you hit that button, you say clear and you hit the button, do not ever touch the patient until the defibrillation has gone off. And if you are concerned because a number of seconds have passed and it has not gone off, the first thing you should do is turn off the defibrillator. Then you can return it on and figure out what the issues are. But you never, ever want to touch the patient to try and sort of figure out what's going on because it may defibrillate the patient while you're touching the patient. And so you have to be very careful in that regard. It does happen On rare occasion, it could be very dangerous to the medical personnel. Yeah, so Uzo, you get 100% on this. You're now ready to graduate fellowship, but we still need you for another 6 months, so please don't leave yet. Okay. All right, and so again, this is pre-excited AFib. The risk is 1 per 1,000 patient years, or roughly 1% over the course of a patient's life. The two most common answers to this question of how to acutely manage this would be either, as Uzo said, procainamide, or to DC defibrillate the patient. And chronically, you would want to ablate this. So if a patient came in with this type of rhythm, with this fast of a rate, we would be very worried about this patient in regards to risk for sudden cardiac death. And this would be a patient who we would not allow to go home unless they were either on an agent that blocked and prolonged the pathway refractory, such as amiodarone, procainamide, maybe flecainide, or they were ablated. And in the present era, most of the time when we see a patient like this, once we convert them, we admit them to the hospital and we set them up for an ablation the next day or the next week or something like that, because this is if you see a patient like this, you have saved a person's life. There's no question this would almost certainly degenerate into a life-threatening problem very rapidly.
Dr. Pass, I have a question.
Yes, of course.
Do they sit in this for a long time, or is this one of those, like, say so a patient shows up in the ER in this kind of rhythm?
Yes.
Do we always assume that this is like an acute versus like a patient who comes in with like a regular AFib who we know they could have been sitting in it for hours?
It's a very good question. I don't know how long the patient is in it. My suspicion is that if you have this type of rapid conduction, the chances are you have not been in it for very long, because you probably would have died already.
Okay, because I was going to ask, because if this was an AFib, we would be talking about things like anticoagulation, looking for clots and all of that. But whenever I guess that doesn't apply in this case. And the reason I was asking was, that was what I was asking the lab.
Yeah, Oza, no one's ever asked me that question. It's a very good question regarding, why do we not care about clots and things like that, that we normally would be very concerned about in somebody who has atrial fibrillation? And the reason is exactly what we're talking about, which is that this is so profoundly life-threatening. It's so likely to degenerate into a life-altering problem that we would not normally, we would assume that somebody who's in this went into this in less than 24 hours. And we would assume that it's unlikely that they've been in it for longer than that, or else they probably would have died, particularly with the conduction characteristics of this particular patient. And so in this case, in this type of scenario, we would not worry about that. Certainly, I would perform an echocardiogram after I cardioverted just to see what the function looks like, et cetera. But it's a good question, but I think that it is unlikely that somebody in this rhythm would stay in this rhythm for more than 24 hours. And even if that were the case, even if we documented that this patient somehow had survived for 24 hours, the risk of this is so great that we probably would just proceed with getting them out of it. It's a very good question. Okay, so David Barris, you're in the nursery, you're doing consult service, and you're asked to see this patient. So I'm going to ask you, what is the diagnosis? How would you treat this? Or would you treat this? And what is the long-term prognosis? Because the mother wants to know what she should expect.
So this looks like Flutter, classic sawtooth waves. In terms of prognosis, I know it is good, that it usually resolves. In terms of treatment, I think that you can use Diltiazem to rate control this kind of patient, assuming that we're in the newborn nursery and we are, hemodynamically stable. If we are hemodynamically unstable, I believe we can do cardioversion. I think other treatments are like beta blockers, like metoprolol. And then in terms of, I think that would be a good start.
So first thing I would say is, generally speaking, we don't use IV calcium channel blockers in newborns. The reason for that is that in the 1980s, there were a number of papers demonstrating cases of cardiovascular collapse in infants who received IV calcium channel blockade, particularly verapamil. Now, there is some debate amongst electrophysiologists as to whether verapamil is necessarily specifically dangerous to newborns or diltiazem, and whether it is really more just that because it comes so concentrated, as I mentioned earlier, it might be that patients are getting the dose too fast, and maybe newborns are a little more sensitive to that. But because the baby is so small, and because the dose is so small, and because it comes in such a concentrated IV form, maybe patients were just getting really big boluses rapidly. And there are many who believe that if it's given slow enough in a newborn, it might be safe. However, in 2020, 40 years since then, we still would say that the use of IV calcium channel blockers are contraindicated in a newborn. So you never really want to use the verapamil or diltiazem in that setting. When I wrote a paper on the use of IV diltiazem, which is the first paper in children back in like 2001 or 2000, we had like an 11-month-old or a 10-month-old in whom we used diltiazem, and it was quite noteworthy that that patient tolerated the medication and did well. So it is possible that maybe at younger ages, these agents can be used, particularly diltiazem, which does not appear to be as hemodynamically embarrassing. But I would say that generally I would not use a calcium channel blocker in a newborn. Now, you're right, David, that in an older patient, we would want to rate control though. So your general principle is a good one, which is we would want to rate control somebody when they're older. But in a newborn, we normally would not rate control. We would just get the patient out of the arrhythmia. And so normally we would cardiovert somebody like this. We would not, as they say, we would not pass go or collect $200. We would just go ahead and cardiovert this patient. Because of what you said earlier, which is that the prognosis is very good. Usually when you cardiovert a newborn in atrial flutter, it's, shall we say, one and done. You do it and then the patient is fine. And the likelihood of recurrence is probably in the 10% or lower range. And by a month or two out from this episode, if you have not had a recurrence, you basically never have a recurrence. So, excuse me. So how would you cardiovert this patient, David?
So I believe that you could use, the dose that we had talked about earlier, the 0.5 to 1 joules per kilo.
That's right. So we would give, and would you give this as a synchronized shock or an asynchronous shock?
Synchronized.
Right. You would give it as a synchronized shock. Now, interestingly, years ago when I was with Leo Lieberman, and he was my fellow, we wrote a paper showing that actually the effective dose was like 0.3 per kilo of energy, but really no one does that. 0.5 to 1 joules per kilo is the standard approach to cardiovert somebody and get them out of it. Now, let's say that it did come back, David, the next day. What would you do then? Well, what would your options be, I should say, because there is really no right answer to this.
So I suppose your options are to try to cardiovert again.
Okay, you would certainly cardiovert again, but as Einstein said, the sign of insanity is doing things the exact same thing and expecting a different outcome. So, so you would cardiovert, but was there anything else you would do other than that? Normally, if somebody has already had a recurrence, we would do something more than just cardiovert, although we would certainly cardiovert.
I suppose you could also start like an oral agent.
Yeah, that's correct. That's what we would normally do. So what agent would you prefer to use?
I believe propranolol, could that be an option?
Yeah, absolutely. Propranolol probably would be the most common thing that people would use in this circumstance. It's easy, it's cheap, it's easily available, and we know it has a long track record of being safe in infants. So propranolol is often used. Some electrophysiologists or cardiologists will use sotalol in this setting. Some people will use even amiodarone. You know, interestingly, in certain developing countries, it is easier to get amiodarone than it is to get things like propranolol. And so, and then in other countries, amio is the first line for treatment of any SVT in babies and small children because it is a once-a-day medicine and because it is only used typically for a few months. So I think propranolol would be a perfectly reasonable choice. And what's the usual starting dose, David, of propranolol?
Is it 1 mg per kg per day divided Q8?
Yeah, it's usually 1 to 2 per kilo per day. You know, if you actually look in the textbook for a newborn, it's really supposed to be given Q6. But you'll notice, or you have surmised, that we never dose at Q6. Never is a strong word, but we often do not. And the real reason we don't is simply because it's hard for parents to give a medication every 6 hours. So in recognition of that, we give it every 8. But if you really look at the pharmacokinetics of this agent, it really is sort of gone by the 6th hour. So it makes a little bit of no sense, but it's easier. Most parents will be compliant with the Q8 regimen, not as easy with the Q6. So when we have a very difficult to treat arrhythmia, we'll sometimes go Q6, but usually we prefer not to. Okay, very good. All right. This is a 6-year-old who is referred for an elevated heart rate. So I'm going to ask Dr. Babia what he thinks could be going on here.
Good morning. So the rate is about 150. Then I'm looking for P waves before each QRS and QRS after each P wave. And in lead 1, I believe I see P waves before QRS, but with some pre-excitation, if I'm not mistaken. And then in second lead, I don't see P waves. And in view 1, it's probably a very short PR interval if that's a P right before the QRS.
I agree with that. Is the axis of the P waves normal or abnormal?
So it's positive in 1. So if that's the P wave, then it's negative in 2, and negative in 3, and negative in AVF, which says that it's not sinus, it's more of a low atrial rhythm.
Right. And what is the heart rate, Sergey?
So it's a little bit faster than 150. It's probably 160, 170 maybe.
Right. So when we use the term low atrial rhythm, that's often used to denote a non-sinus, slow, alternate rhythm, like you'll see on a Holter patient when they're asleep, maybe in a non-sinus atrial rhythm. We sometimes also refer to that as a wandering atrial pacemaker. But at a rate of 160, we would not normally refer to that as a low atrial or a wandering atrial pacemaker. This is clearly a tachycardia.
Ectopic atrial tachycardia.
So it could be ectopic atrial tachycardia. Certainly the fact that the P wave is very abnormal in appearance and has an unusual axis would be consistent with that. The thing that goes in the differential, though, with that, is there anything else that this could be? So I certainly agree. I would give you 90% credit for that answer if you said that I think this is EAT. But is there another diagnosis that might explain this?
Well,
In EAT, is the PR interval typically normal, or is it short, or is it long?
in EAT, it should be, I guess it should be shorter.
No, actually, in EAT, oftentimes patients have a long PR. They often are in first-degree heart block. It's not a guarantee, but it's often a good hint or clue, I should say, for EAT. So the other diagnosis here that I think should be in your differential is PJRT, right, with a long R QRS to P interval, right? This is a very long interval. It's like, 170 milliseconds. So we remember that PJRT stands for the permanent form of junctional reciprocating tachycardia, but really that is a misnomer. And really PJRT is probably just a form of ORT with a very slowly conducting concealed accessory pathway. And it's characterized by a long RP interval and a normal or short PR interval. And that's as opposed to EAT, which usually also has a long RP interval, but has a long PR interval. And so again, you imagine that this P wave is conducting down the AV node to the QRS, and then it's going back up the accessory pathway, taking a long time because this pathway conducts slowly, which is a classic characteristic of PJRT, and then conducts back to the AV node and then slowly back up the accessory pathway. And this is the reason why people with PJRT typically have slower than average SVT, because one limb of the circuit conducts very slowly. It is also the reason why patients with PJRT are often stuck in tachycardia. So it often results in a chronic tachycardia and is commonly associated with ventricular dysfunction. And the most common location that these pathways are located is the posterior septal region near the mouth of the coronary sinus. And the differential diagnosis for this is EAT or PJRT. And it's always, sometimes we never know the answer until we go to the cath lab and figure it out. And so these two can be hard to determine between the two. And so the treatment for this is either to ablate it, which is the most effective and traditional way that is going to cure you, or you can use medications. But these tend to be very difficult to treat medically, because what often happens is you just slow the tachycardia without actually breaking it completely. So it's actually can be a very challenging arrhythmia to take care of. And it's also often dangerous ablation because the patients go to the cath lab with poor function, and then you have to anesthetize them. I remember I once had a patient who came into the hospital in PJRT who had horrendous ventricular function, really, really bad, was on a lot of inotropes. And we decided to just medically manage it because we were so frightened of anesthetizing her. And so we got control of it. And then after she was in good control, the patient was so frightened of going to the cath lab that it took 9 years before I could convince her to come to the cath lab to get rid of the PJRT. And it was because she was frightened, but I was frightened of taking her to the lab because her function was so poor. I was worried that she might end up on ECMO just from the negative inotropy of intubation and sedation for the procedure. So in retrospect, I probably should have taken her to the lab when she was less upset about going to the lab. Didn't have much of a choice, I should say. So probably the treatment of choice is ablation, but medications are also reasonable as well. All right, guys, I'm going to stop a little early today. I have to do one or two things before conference. Thank you for joining me today, and hope everybody has a wonderful week. I'll see you during the day. Take care.
Thank you.
Thank you, Dr. Bass.
Be well,
Thank
everybody.
you.
Thank you.